Hi, I'm Amy Reyes. This week from Rheumatology Network, we formally launched a podcast called Overdrive. To kick off the series, Dr. Kim Gorgans, a psychologist with the University of Denver and a Rheumatology Network board member, interviews Dr. Linda Mona, a clinical psychologist who was also a patient with chronic disease. They discuss maintaining a good relationship with your patients, which Dr. Mona says holds more benefits than you may realize. And this week we featured a study in arthritis care and research that shows rheumatoid arthritis patients actually have a lower rate of type 2 diabetes than people without RA or patients with hypertension, osteoarthritis, and psoriatic arthritis. In fact, patients with psoriatic arthritis have a higher risk of diabetes, they report. And there have been numerous studies in recent years that test the utility of activity trackers in clinical research. Researchers writing in Arthritis Research and Therapy test the concept in a small pilot study of patients with gout. The goal was to better determine the frequency of gout flares, and it seemed to provide some insightful evidence to support more trials in the future. And in our one-on-one interview today, we talk with Dr. Daniel Solomon. He is professor of medicine at Harvard Medical School and chief of clinical sciences in the Division of Rheumatology at Brigham and Women's Hospital. He currently serves as editor-in-chief of the Journal of Arthritis and Rheumatology. This week, Dr. Solomon and colleagues published a commentary called The Infodemic of COVID-19. They discuss how the pandemic has impacted the journal, the medical publishing world, and how clinicians can best navigate current challenges. They begin by highlighting the infodemic surrounding hydroxychloroquine and the cytokine storm. Please join me in welcoming Dr. Solomon.
Sure. I'm Daniel Solomon. I am a professor of medicine at Harvard Medical School, and I'm the chief of clinical sciences in the Division of Rheumatology at Brigham and Women's Hospital. And I currently am the editor-in-chief of Arthritis and Rheumatology, which is where our editorial or commentary was published that we're talking about today. Sure. Well, this was a commentary that we wrote, myself and the deputy editors of Arthritis and Rheumatology, and we felt compelled to write about what we describe as the infodemic, and others describe it that way as well, because there's so much misinformation regarding all aspects of the pandemic, from diagnostics to treatments to prevention. And in the rheumatology world, because COVID affects the immune system and often presents with extremes in inflammation, many treatments that we have used in rheumatology have been considered as possible treatments for COVID. And this includes hydroxychloroquine, as well as some of the anti-cytokine therapies against IL-6 and IL-1, as well as a drug as simple as steroids, dexamethasone. So as rheumatologists, we're very knowledgeable and aware of these drugs and aware of things like the Cytokine Storm syndrome. And so listening to how the misrepresentations in the lay press and on TV and social media have impacted the pandemic, the public health efforts, and even our patients because of difficulty getting access to routine drugs like hydroxychloroquine. So I think we all felt very compelled and moved to speak about this issue, and we talk about two specific examples in this commentary. One is the hydroxychloroquine, and the second is the cytokine storm syndrome. And I think they're both just really compelling examples of this infodemic. That's mostly correct. Mm-hmm. I think that, I look at hydroxychloroquine as an example, just a very typical example of how our optimism and reality sets in with any therapeutic. There's kind of a similar arc. This arc has been compressed to several months, 3 to 6 months, as opposed to the years that we typically see with different compounds. But, initially there was the observation or the recognition that hydroxychloroquine had some corona activity against coronaviruses, not large studies, not necessarily studies done in people with COVID. I mean, these were other coronaviruses, but there was, biologic plausibility to the notion that hydroxychloroquine might have some action against COVID. We didn't know which patients, whether it was preventive, whether it was early, whether it was mild, whether it was severe, but there was some biologic plausibility. And then people made observations in, small case series where they saw that patients who received hydroxychloroquine, often with other antibiotics, hydroxychloroquine is an anti-malarial. It has some immunomodulatory effects as well. So it seemed like an interesting drug. It's been on the market for decades. So people felt comfortable using an approved drug. It wasn't a new investigational drug. And in these small case series, there was some suggestion that it might work. But we all know that a case series is an uncontrolled experiment. You look at 3, 5, 10 patients, but you don't look at the counterfactual. What would have happened if they didn't get this? You don't have the randomized control arm. And so a small case series is just that. It's just a small case series. It sometimes gives us some insight. Yeah, maybe there's something going on here. And then we go to more formal observational studies. We look at groups of patients that did or did not receive the drug. So now we have a contrast. And we try to match them up in certain ways, or we adjust for differences in regression analyses. These are typical observational studies. And maybe the first one looked like there might be some benefit, but quickly, as people did larger and better designed observational studies, those too found no benefit. And at the same time, people were organizing randomized controlled trials, which is our gold standard. It's how we prove a drug works or doesn't work. And it's kind of, we think about a hierarchy of evidence, from kind of biologic plausibility to case series to poorly done observational to better done observational to randomized controlled trials to very large randomized trials or meta-analyses of randomized trials. And so we worked our way through the hierarchy just over weeks, if not 2 or 3 months. And as we got to the randomized trials, now there's been 3 or 4 randomized trials that have shown no benefit. Have these trials tried the drug at every dosage in every subgroup of patient? No. But now we have a lot of data to suggest it doesn't work. So in reality, the onus of proof is now on the people who still believe it works, because all the data, the best data, show that it doesn't work. And so might it work? It's possible. I wouldn't say very possible. I'd say there's a slim possibility that in certain subgroups, at certain dosages, it's possible it could work, but all the data is suggesting, all the best data is suggesting it doesn't work. So observational studies can be very useful, and they kind of pointed us in a direction, but then as larger and better designed studies were conducted, it really argued against it. So it's an example of how kind of the information got out beyond the science. And as I think we point out in the commentary that science is somewhat self-correcting. We look at something, we make some best guess. Initially we weren't sure masks were useful. Over time, we've realized masks, and now in our health system, we're being, the recommendation is to wear eye protection. So, opinions evolve as the science evolves. And we have to understand that. And the infodemic has kind of gotten beyond the science at many points along the way, whether it's about hydroxychloroquine or other therapeutics or just other observations.
Mm-hmm, mm-hmm. I find that sometimes the science is just too complex for the layperson, patient, politicians, community leaders to grasp. So this kind of misunderstanding is probably inevitable, especially with, a pandemic. and it may never die. Let's go on to cytokine storm syndrome. What were your thoughts on that?
Yeah, so this is a more complex issue because cytokine storm is a kind of a term that's thrown about, and it means slightly different things in different contexts. Typically, we use it when we talk about a hyperinflammatory state, a state that might be provoked by an autoimmune disease, it might be provoked by an underlying cancer, or it might be provoked by an infection. Initially, our body's immune system, through antibodies as well as other means, fights off infections. The innate immune system, as well as other aspects, antibody-mediated, are very effective at keeping most infections in check. But infections set off a cascade of the immune system, which can become self-promoting in a way, and that cascade can cause, that inflammatory cascade can cause damage, and we see that again. We see that in autoimmune diseases when they're out of control, or some cancers, and it's probably been the case with many infections other than coronavirus. But with coronavirus, it seems, and I'd say that we haven't really resolved this issue. It seems that hyperinflammatory or cytokine storm syndrome with a variety of cytokines, including IL-1 and IL-6 and others, are at play in certain patients. And so part of the body's reaction to the infection causes its own pathology, its own set of problems. And it might cause the deposition of complement, another part of the immune system, to cause problems in the kidneys, problems in the heart, a hyperthrombotic state where there's blood in different parts of the body. So all these are part of the pathology of COVID-19 in certain patients. Thankfully, not in most patients, but in certain patients. And so this recognition of the cytokine storm was discussed early on by a lot of clinicians as well as immunologists as being something that we had to think about in the pathophysiology as well as in thinking about the therapeutics. And so very quickly, people started to think about therapies that might interrupt the cytokine storm, therapies that are targeted at those cytokines, IL-6, IL-1, or more broadly across many cytokines in many aspects of the immune system by using something like steroids or dexamethasone. And so that set off a number of trials, and some of those are published and some of those are ongoing. And unfortunately, even though we measured IL-6 levels in patients and they were elevated, and we thought perhaps it was part of the pathology, and if we interrupted IL-6, that might help these patients, it also may be the case that IL-6 was a compensation that was a good compensation, not a toxic compensation. And so so far, the randomized trials of IL-6 blockers have been mostly negative. Mm-hmm. So again, we start with this biologic observation, elevated IL-6. We move to some observational studies or case series where we give IL-6 blockade. And we were doing it, my colleagues were recommending it to patients in the ICU here at Brigham and Women's Hospital who were very ill and had measured elevations in IL-6. We were giving IL-6 blockers. Maybe there was some improvement in some of the patients, but these are uncontrolled case series. And then we develop controlled observations, and maybe there was some benefit, but less clear. And then we quickly move to randomized controlled trials, our gold standard. And so far, the published randomized trials have been negative. There are still randomized controlled trials that are ongoing, but there's much less enthusiasm for IL-6 blockade. However, IL-1 blockade, another cytokine, there's still ongoing trials. Observational studies are more suggestive. So it's an evolving story. Again, it's this example of kind of the self-correcting nature of science. as scientists, and I think you make a very important point, that it's confusing. It's confusing to clinicians and scientists. It's very confusing to the lay public, and it's confusing to, elected officials, because the science evolves. It's evolving incredibly rapidly, and we should be thankful that there are so many dedicated, clinical scientists and basic scientists looking at these issues. But the story changes week by week, and we look at the evidence and we try to, glean the truth from different pieces of data. And that's what's going on. And the infodemic, again, describes how the information culture that's 24/7 is kind of getting beyond what the science is telling us. And how do we deal with that as journal editors? How do we deal with that as a public? How do we deal with that as clinicians is really kind of an interesting aspect of what we're living through.
Right. It's definitely a challenge for everyone.
Yeah. Yeah.
We write for a physician audience. So what would you recommend to rheumatologists and general practitioners who read our site? How should they approach this infodemic?
Yeah, I think it's for clinicians, I think it's as we always do it. We look for the best evidence published in peer-reviewed journals. And again, there's a hierarchy of evidence that we're all very familiar with. A biologic observation to a case series, to a small observational, to a better observational, to a randomized trial. We all know that hierarchy. And as clinicians, we should be critical of the literature that we're reading. And when it's reported in the lay press, we should go back and look at the source, the original source, because we're smart. We know how to evaluate literature, and we should evaluate the original source literature and not just quote, the New York Times or another, the lay press or somebody you hear on the news. We should actually, as clinician scientists, go and use our brains to critique the literature. And that should give us insights, how we discuss it with patients, how we discuss it with colleagues, how we treat patients. So I think it's all, we all kind of know how to do it. It's just happening so quickly that sometimes we don't have the hours in the day to go and look at the literature as we should. And that's, as journal editors, that's kind of our job, is to, to critique the literature carefully, only publish what we think is worthwhile. And that's kind of, again, that was the impetus for us writing this piece.
Mm-hmm. Okay. And any recommendations for the general public and patients who might be listening to you now?
Yeah, I think the good news is some of our best scientists are on air most days. I mean, Dr. Fauci, who I'll say has done some important rheumatology research in his life. You can find him on air most days talking about the state of COVID, whether it's drugs or vaccines, et cetera. And, he's a very careful scientist, and he's a very careful spokesperson regarding public health and therapeutics. So I think that trying to find sources like, Dr. Fauci, like, Dr. Sanjay Gupta on CNN, I think, he's a careful and spokesperson for science and public health. He's not peddling a point of view. He's not peddling a drug. He's really trying to report in a responsible way. And so I think that there's good sources out there, but sometimes they're being drowned out by sources which aren't so great.
Mm-hmm. Yeah. And any final thoughts then for our readers?
Yeah, I think that I listened to Dr. Fauci yesterday in a forum that was here at the Harvard School of Public Health, and I was heartened to hear him talk about vaccines possibly being ready by December, January, February. And I think that we all have to take this pandemic obviously incredibly seriously, and we have to hope and pray that effective and safe vaccines are on their way. And we have to, as clinicians, educate our patients about the importance of vaccination. And as the public, we have to recognize that when you get vaccinated, it's not just for your own good, it's for the good of the public. And so if you have some concerns, it's good to discuss those concerns. But again, you're not just getting vaccinated for yourself, you're getting vaccinated to stop the transmission of an infectious illness that kills people. And so the importance of vaccination should not be underestimated for public health.
Mhm. Right, right. And be patient as well. I would say
Yeah.
to the public, it won't happen tomorrow, but eventually there will be a vaccine. So,
Yeah.
well, thank you. Thank you for your time today. I appreciate that.